Assalamu alaikum. Today we'll start our second round of MS online presentations, and we'll begin with EAU guidelines on non-muscle invasive bladder cancers. I'm Dr. Abdul Rafiq, and these are the contents of our site. First, I will start with an introduction of guidelines. There are some different terms associated with them, level of evidences. Then we'll dissect individual guidelines one by one, starting from staging, then diagnosis, disease recurrence, disease management, and then follow up the patient. Guideline statements are basically recommendations for clinicians to improve patient care, which are based on systematic review of evidences and the pros, benefits, and harms towards the patient. They balance that in there. And setting that in mind, the aim of this is to provide practical recommendations on the clinical management or non-muscle invasive bladder cancers and their management. So clinical guidelines are the best evidence-based to the experts. However, following them does not necessarily give the best result. Guidelines can never replace a clinician when making treatment decisions for individual patients. Rather, they help to make a focused decision. Guidelines are basically just they guide you. They are not mandates or word of law. You have to follow them as such. There are certain words which are associated with them, which define the strength of the recommendation. They are either strongly recommended or weakly recommended, but they're not mere adjectives. There's a science behind them. There are certain key elements which go into defining a guideline. So some of the key elements are the overall quality of the evidence upon which the recommendation is based on, the magnitude of the effect on the patient, the certainty of the result, the balance between a desirable and non-desirable outcome, the impact of the patient values and preference on the intervention, and the certainty of these patient values and their preferences. Upon these key elements, we term a guideline, whether it's a strongly recommended or weakly recommended. Okay, and then there's the quality of evidence. This is the hierarchy, which is the cornerstone of evidence-based medicine. Think of it as a pyramid. On the top, we have the evidence obtained from meta-analysis of various randomized studies, followed by evidence obtained from a single randomized control. Then we have control studies, other experimental studies, and at the end we have clinical reviews, experts, and experiences of respected authorities. And now with EAU guidelines on the muscle invasive bladder cancer. First, just to epidemiology and
just a moment. Assalamu alaikum, Arif. Arif, can you hear us?
Yeah.
Please mute your mic, please, Arif.
Yes, sir, I can hear you.
Right.
Can
So
you
good.
hear me?
Yes, good to see you.
Oh, sorry.
Sorry for this slight interruption. We have got a friend in Bangladesh, in Dhaka. As I was introducing him day before yesterday, he also wants to contribute and wants to be a part of this forum. So maybe when he is connected, he will have his input. Actually, this subject of non-muscle invasive bladder tumor was his research topic in MS when he was doing, I think, in 2005 or 6. I'm not pretty sure. So when his connection is made, then he will have his say on the subject. So right. So please continue, Rafi.
Okay, now we proceed towards the guidelines, individually dissecting each statement one by one. First of all, just a few slides on epidemiology. This is basically a review of what we did in the first round. Worldwide, bladder cancer is the 11th most commonly diagnosed cancer. In men alone, it's 37, and when combined both gender, it's 11th most common bladder cancer. Worldwide incidence rates is 9 in men and 2.2 in women. However, geographic variations do exist. Worldwide, the bladder cancer mortality rate is twice as more in men as compared to women. However, 75% of the patient of bladder cancer present in the disease that is confined to mucosa or submucosa. In younger patients, this percentage is even higher. The higher prevalence rate is due to long survivability of the patients suffering from these cancers. Several risk factors have been connected with bladder cancers, which includes tobacco smoking, which accounts for 50% of the cases, occupational exposures to aromatic enzymes, polyrhythmic hydrocarbons, fluorinated hydrocarbons. They are also associated with the bladder cancer, account for 10% of the cases. Family history do have a little impact. Genetic predisposition has an influence on the incidence of bladder cancer, but its impact and susceptibility on other risk factors. Chlorination of water, arsenic, ionizing radiation, cyclophosphamide, and pioglitazone is also linked with bladder cancer. Staging and classifications. So these are the recommendations, and we will study each statement one by one in the following slide. So it's strongly recommended to use a 2017 TNM system of classification for the depth of invasion. So TNM classification of 2009 is approved by Union Internationale contra il Cancer, and this is the 8th edition. It defines the papillary tumor confined to mucosa and invade the lamina propria are classified as stage TA and T1 respectively. Flat, high-grade tumors that are confined to mucosa are CIS. The term non-muscle invasive bladder cancer represents a group definition, and all tumors should be characterized according to their stage, group, grade, and further pathological characteristics. This is the TNF setting. We have studied it in the previous slide, so I will just review it here once again. TX, tumor cannot be assessed. T0, no primary tumor was found. TA, a papillary non-invasive papillary carcinoma. TIS, a flat carcinoma in situ. T1 is the tumor invades in the lamina propria. This is the non-muscle invasive category, and the rest is the muscle invasive category. T2, muscle invades in muscularis precosa. Superficial, in A category we have a superficial invasion, and B category we have deep invasion. In T3 there's invasion in perivesical soft tissue. A is microscopic and B is macroscopic, and T4 is extravesical tumor directly invades into following prostatic stroma, seminal vesicle, uterus with vagina, pelvic wall, and abdominal wall, and it is further divided into A and B category. So this is the nodal and metastatic categories. Cannot be assessed at X, no lymph node found. Single lymph node metastasis in true pelvis is 1, 2 is multiple in true pelvis, and 3 lymph node has metastasized to common iliac lymph node. And the M category, M naught, there's no distant metastasis, and M1 is distant metastasis. This is further divided into two groups, A and B. So on the topic of T1 subclassification, the depth and extension of invasion into lamina propria has been demonstrated to have a prognostic value. However, it is not yet a part of our TNM system. Then the use of both 1973 and 2004 and 16 grading WHO grading system. So both these systems are advised to be used by the guidelines. The guidelines are still based, since the guidelines are based on 1973 and 2004 classification, since most of the published data is in the 1973 classification. The WHO 2004 classification provides slightly better reproducibility as compared to 1973 classification. these are the two different classifications. The WHO grade is grade 1, well differentiated, grade 2, poorly differentiated, grade 3, grade 2, moderately differentiated, grade 3, poorly differentiated. As compared to the 2004 and 16 WHO grading, we have papillary urothelial neoplasm of low malignant potential, low grade and high grade papillary urothelial carcinomas. Now on to carcinoma in situ. These are flat, high-grade, non-invasive urothelial carcinomas. They also mimic inflammatory lesions during when seen on a cystoscopic examination. Carcinoma in situ is often multifocal and occurs in bladder as well as in upper urinary tract and prostatic duct and prostatic urethra. We also classify CIS according to the following given types. It's either primary, secondary, or concurrent. In primary, there's an isolated CIS with no previous or no recurrent papillary tumor and no previous CIS. Secondary, CIS is detected during a follow-up patient with a previous tumor that was not CIS. And concurrent is CIS in the presence of any other urothelial tumor in the bladder. So these are some of the WHO histological classifications of flat tumor. Flat tumors are flat lesions are basically of two types. They are either malignant or non-malignant. In non-malignant varieties, we have urothelial proliferation of uncertain malignant potential, reactive atypia, which is just the inflammatory type. Atypia is a misnomer. Atypia of unknown significance and urothelial dysplasia are predisposing or pre-malignant conditions. Urothelial CIS is a high-grade malignant lesion.
Now, just a word about CIS from retrospective analysis of the data. If you go to any institute and you ask for the prevalence of CIS in their series of bladder tumors, some would say that they will be able to pick some of the cases of CIS, and some would say that they will not be able to pick cases in probably if you do an analysis of the previous 1 year or 2 years or 5 years. So what's the difference? The difference is that the difference lies between the kind of practice, the cystoscopic biopsy practice that the institute is doing. For instance, if I go for the bladder tumor, I must have got some imaging or an impression that this patient has got hematuria and the cause of hematuria is probably a tumor. Then on ultrasound, I might find something which is bulging into the lumen, and I go for cystoscopy. Sometimes I do CT scan in our setup. Sometimes I don't do CT scan before doing cystoscopy. One way of doing a standard practice is to go for flexible cystoscopy first, and then if the evidence is there of a growth, then you go on to have cystoscopy proper with biopsy. If the most standard way is to do a CT scan first and then go for cystoscopic biopsy. But for all means, if you go for cystoscopy and if you see something in front of you, then you take a resection of that tumorous growth from the surface as well as something from the depth of it, meaning to say from the floor of the tumor. That would give you something called muscle invasiveness or no muscle invasiveness. Now, if you don't do random biopsy, which is without any purpose, but the purpose is very clear, the purpose is to find out something which is beyond the surface. If you are in search of CIS, something beyond the surface, which is not on the surface, it won't give you anything on the surface, and since it is flat, then it will not be picked up unless and until you do random biopsies. So random biopsy or biopsy which is maybe diagonally opposite to something which is a growth on one side of the bladder is always of benefit in terms of CIS. So if your institute is having a policy of doing random biopsies, then you will have a high incidence or high prevalence of CIS, otherwise you don't have it. So that depends upon the practice of doing cystoscopy and a proper cystoscopy and a proper biopsy protocol.
Right. So in the previous slide, I discussed that there are some variant of urothelial carcinomas. So I've enlisted here some of the variant histology of urothelial carcinoma. The urothelial carcinoma in itself is 90% most common type of histology that's found in these patients. Urothelial carcinoma with partial squamous and glandular or trophoblastic differentiation, micropapillary. They have minute fibri papillae on their cell. Is very progressive and have a bad prognosis or a poor prognosis. Nested variant. They have cluster of cells nested. Microcystic urothelial carcinoma, plasmacystoid, giant cell, signet cell, diffuse and undifferentiated lymphoepithelioma like tumors. They are similar to the lymphoepithelioma that is present in the nasal cavity, I guess. Some urothelial carcinoma with other rare differentiations, small cell carcinoma, sarcomatoid urothelial carcinomas. Other extremely rare variants do also exist. So some variants of urothelial carcinoma have poor prognosis than pure high-grade urothelial carcinoma. The presence of lymphovascular invasion in a TURBT specimen is associated with high risk of pathological upstaging and a worse prognosis. Guidelines recommend not to use the word superficial bladder cancer. The term superficial suggests that all the tumors share the same relatively benign course of low-grade papillary tumor, with sometimes misleading or reassuring to patients that is high with the highly malignant subcategories of CIS and high-grade E, A, and E1 tumors. So it's not recommended to use these. Now, guidelines on diagnosis. These are the listed guidelines by the category. We will dissect each statement one by one. So take a history focused on urinary tract symptoms and hematuria. So if a patient presents with signs symptoms that we are suspecting that he is suffering from and he has a bladder cancer, like that he has a hematuria, both either macroscopic or microscopic, or in some cases, as in CIS, he might have lower urinary tract symptoms. We should take a focus history, focusing on the symptoms of urinary tract. Physical examination is also mandatory. However, they are not so revealing in the non-muscle invasive bladder cancers. Use renal and bladder ultrasound and CD during the initial workup in the patients of hematuria. So ultrasound is an adjuvant to physical examination. It has moderate sensitivity to wide range of abnormalities in the rule out all the causes of hematuria. So it cannot reliably exclude the presence of upper tract urothelial carcinomas and cannot be replaced by a CD urograph in this context. Once a bladder tumor has been detected, perform a CD urograph in selected cases. That is, a tumor is located in a trigome, it's multiple or a high-risk tumor. CD urography is used to detect papillary tumors in the urinary tract, which is often indicated by filling defects or hydronephrosis. IVU is an alternative CD if it's not available, but particularly in the muscle invasive tumors of the bladder or upper urinary tract, CD urography provides more information, including the status of lymph node and neighboring organs. The necessity to form a baseline CD urograph once a bladder tumor has been detected is questionable due to the low incidence of significant finding. These findings include upper urinary tract urothelial carcinoma, the incidence of which is 1.8. But however, if we are finding a growth in a trigome, this incidence increased to 7.5. So a growth in the trigome is a risk factor of upper tract urothelial carcinoma. The risk of upper urinary tract during follow-up increases with patients of multiple or high-risk tumors. The role of multiparity MRIs have not been established in the diagnosis of bladder cancers and staging. A standard methodology reporting in patients with bladder cancer was recently published and it requires further validation. perform cystoscopy in patients with symptoms suggestive of bladder cancer or during surveillance. It cannot be replaced by cytology or any other non-invasive test. So, cystoscopy remains the gold standard for the initial diagnosis of bladder cancer. Cystoscopy is combined by urine cytology, which may detect lesions that are otherwise missed by cystoscopy, such as lesion in the upper urinary tract. The initial cystoscopy is typically done in an outpatient setting, in an office setting, with a flexible cystoscope. The diagnosis of papillary bladder carcinoma ultimately depends on cystoscopic examination of the bladder and pathological evaluation of sample taken either by a cold cup forceps or a resection or of the resection with a resection. In men, use a flexible cystoscope if available. So, a flexible instrument with topical intraurethral anesthesia such as lignocaine, lubricant installation results in better compliance. So men find it easy and they are more compliant with a flexible cystoscope.
So just to update you on flexible cystoscopy, for the past 6 months, we have added this tool into our regular clinic. So in every clinic, every patient who comes to you initially for the very first time with complaint of hematuria, so before going on to have a conventional rigid cystoscopy and resection of the tumor or biopsy of the bladder, we always do something called flexible cystoscopy under local anesthesia. So that is one service that has been added into our protocol recently, slightly recently, like 6 months back. So that has given us a lot of space to think. By space, I mean if we want to do something called diagnostic cystoscopy under general anesthesia or spinal anesthesia, then that would become a kind of a burden on the already long waiting list. So just to uh, make arrangement for another thing in between, we have added this thing which can be done very easily for many patients in less amount of time and with appreciably good result in terms of detection of growth, whether it is there or whether it's not there. So this service has been added, and now we are slightly better off than what we have been doing previously.
Next up is to describe all the macroscopic features of the tumor and mucosal abnormalities during cystoscopy. The features include size, number, and appearance. Use a bladder diagram. This is a typical bladder diagram. We have come across these diagrams during our filter OPDs. So the idea is basically to convey where the tumor is, what is the kind of tumor, what is the size and total number of abnormal findings that we are finding in a pictorial evidence.
So we have got a slightly different diagram, but it's the same. It's the same
Yes.
thing.
Yes, I've seen that.
Right. And that was actually drawn by no one else. It was done by me many years back, probably 20
Right.
years back. So I didn't have any prior training for drawing something.
Right. Use voided urine cytology as an adjuvant to cystoscopy to detect high-grade tumors. Examination of voided urine or bladder wash specimen for exfoliated cancer cell has high sensitivity in high-grade or G3 tumors, but its sensitivity is relatively low in a low-grade G1 tumor. Its sensitivity for a carcinoma in situ ranges from 28 to 100%. Cytology is useful particularly as an adjuvant to cystoscopy in patients with high-grade G3 tumors. Positive voided urine cytology can indicate to a urothelial carcinoma anywhere in the urinary tract. Negative cytology does not exclude the presence. Cytological interpretation is user-dependent. Evaluation can be hampered by low cellular yield, infections, stone, intravesical installations, and In experienced hands, specificity may exceed up to 90%. Perform cytology on at least 25 ml fresh urine with or urine with adequate fixation. Morning urine is not suitable because of frequent presence of cystolysis. Urine collection should be followed by should respect this recommendation. One cytospin slide for a sample is sufficient. In patient with suspicious cytology, repeat examination is advised. Use the Paris system of cytology reporting, a standardized reporting system for defining urine cytology. Urine, diagnostic categories was published in 2016 by Paris Working Group. This includes adequacy, negative for high-grade urothelial carcinoma, atypical urothelial cell, suspicious for high-grade urothelial carcinoma, high-grade urothelial carcinoma, low-grade urothelial carcinoma, or other primary or secondary lesions. So the Paris system of reporting urothelial cytology has been validated by several studies. A word on the Paris system of urine cytology. So the main purpose was to detect high-grade urothelial carcinoma. So considering that in mind, they published a standardized reporting system that includes specific diagnostic categories and cytomorphologic categories for a reliable diagnosis of high-grade urothelial carcinoma. For urologists, understanding the diagnostic criteria, the clinical implications, and the limitations of Paris system is essential if they are to be utilized in urine cytology or non-invasive ancillary tests in a thoughtful and a practical manner.
Just a rule for understanding this whole topic. The higher the grade of differentiation, the lesser will be the adhesiveness between individual cells in the bladder. So if you have got a low grade tumor, then there will be more adhesion between individual cells and less less amount of shedding which can be picked up on urine specimen and urine cytology later on. So if you have got a very high grade tumor, then it will be sort of more yield of this kind of a test. So that is the kind of um, usability of this cytology whenever you want to do something for the patient, and also you want to follow this patient in later period. For instance, if you have got a biopsy specimen in your hand and you have done something for this patient in terms of giving some intravesical therapy, and later on you want to follow this patient, so either you can do a cystoscopy and random biopsy for follow-up, or what you can do is you can do only cystoscopy and combine it with cytology. Now the results of cytology will be interpreted in the light of having the first histopathology report in front of you. If that first histology report tells you that you have started with high-grade tumor, then this cytology will always be of higher value as compared to a low-grade tumor. So that's the kind of reference work that you can do in your follow-up protocol.
So none of the urinary markers have been accepted for diagnosis and follow-up in routine practice or clinical guidelines. So they were developed due to low sensitivity of urine cytology. The following conclusions can be drawn from various studies that their sensitivity is higher at a cost of lower specificity as compared to urine cytology. Benign conditions and previous BCG installation may influence the result of a urinary marker. Requirement for sensitivity or specificity of a urinary marker thus largely depends on the clinical context of the patient, whether it's done in during screening or a primary detection or follow-up. The wide range in performance of the marker and low reproducibility may be explained by patient selection and complicated laboratory method required. Positive result of cytology, Eurovision, nuclear matrix protein, FGFR3 or DERT and microsatellite analysis in patient with negative cytology or upper tract workup may identify patient more likely to experience disease recurrence and possible progression. Promising novel urinary markers are being developed with a high negative predictability value. Now on the topic of TURBTs, biopsies, and pathology. These are the recommendations, and we'll explain it one by one in the following slides. In patients selected of having bladder cancer, perform a TURBT followed by pathological investigation of the obtained specimen as the diagnostic procedure and initial treatment. So the goal of TURBT in non-muscle invasive category is to provide a correct diagnosis and complete removal of all visible lesions. It is crucial procedure in the management of bladder cancers. Outpatient fulguration or laser vaporization of small papillary recurrence can be used in patients with history of low-grade papillary tumor or G1 tumors. Office fulguration of a recurrent disease may be considered as an alternative in carefully selected patient with fewer than 5 or small 0.5 centimeter low-grade appearing lesions in the context of history of prior low-grade TA tumor and negative cytology. The patient with a small tumor fulguration or vaporization of small papillary recurrence on an outpatient basis can reduce the therapeutic burden. There are no prospective comparative studies assessing the oncological outcome of these. TURBT should be systematically performed in individual steps. The steps include bimanual palpation under anesthesia. The steps may be omitted in case of non-invasive or early treatment or invasive disease is planned. Insertion of retroscope under vision, inspection of whole urethral lining of the bladder, biopsy of the prostatic urethra if indicated, a cold cup biopsy of bladder if indicated, resection of tumor, recording of finding in the surgical report and record, precise description of the specimen of pathology evaluation. These operative steps are necessary to give a successful TURBT and help identify the factors such as which assign the disease risk, such as tumor size, number, and multifocality. Characteristics concern of presence of CIS, recurrent or primary tumor, clinical stage that is done by bimanual examination under anesthesia, assessment of clinical tumor stage, adequacy of resection, visible complete resection, visualization of muscle at the resection base, or presence of complications such as assessment of perforation. To measure the size of tumor, we can use the end of cutting loop, which is approximately size of 1 centimeter. So we can use it as a reference to measure the size. The characteristics of tumor are described as senile, nodular, or papillary, or flat. Guidelines regarding individual steps of TURBT. These are the steps, and we will study each one. Perform en bloc resection or resection in fractions. Extrophic part of the tumor followed by the underlying bladder wall up to the edges of the tumor. Avoid cauterization as much as possible in order to avoid deterioration of the tissue. Complete section can be performed by either fractionized or en bloc technique. Is essential to achieve a good prognosis. So piecemeal resection is in section provide good information about the vertical or horizontal extent of tumor. En bloc resection with a monopolar or bipolar current using a thulium or holmium YAG laser is feasible in selected extrophic tumors. It provides high quality resected specimen with presence of retrocessor muscle as well. Take biopsies of abnormal looking urothelium, biopsies from normal looking mucosa, mapping biopsies of trigome, bladder, dome, right, left, anterior or posterior wall are recommended when cytology is positive. In case of a high-grade G3 tumor and tumor with non-papillary appearance, if equipment is available, use PPD biopsies. So this is what you were saying about random biopsies.
Yes. So there has to be a map and a figure that we have been discussing at the back of your mind if you want to do cystoscopy and biopsy, so that when you draw a figure or there is a figure on the uh, on, on the um, on the operative note, then you can always mark where you have taken the biopsy from, which section, right or right side of the bladder, left side of the bladder, on the lateral walls or on the roof, the floor, the trigon, maybe the neck. Now, if it is a neck, then this neck is at 6 o'clock position or maybe at 12 o'clock position. So you all have to make adjustment and an imagination, just like a clock. So it has to be a tubal vision because you are seeing everything through a tube, and that tube is actually your cystoscope. So whenever you want to imagine something and reproduce it, then you are seeing something on again 2 dimensions, and you are drawing it again on a 2 dimension paper, just like drawing a figure on a paper. It's always in 2 dimensions, but then you have to have certain kind of mapping so that when you follow this patient, this will be again taken as reference for yourself, or if somebody else is following this patient, then that person can always refer back to your diagram which you have drawn in the first place.
CIS can present as velvet-like reddish area, indistinguishable from inflammation, or it may not be visible at all. For this reason, biopsy from suspicious urothelium should be taken. It has been confirmed that fluorescence-guided biopsy and resection are more sensitive as compared to the conventional procedure for detection of malignant tumors, particularly CIS.
I think we were discussing this thing when we were actually referring to white light cystoscopy and blue light
Right.
cystoscopy and narrowband cystoscopy. Now, all those techniques are actually done just for the purpose of increasing the depth of vision, so that everything which is beyond the surface, which our normal eyes cannot see and the white light cystoscopy cannot see, you resect everything so that you have a very good knowledge of the patient's disease, whether it has progressed into the deep muscle layer or it is still above or superficial to lamina propria. Now that dividing line is actually the dividing line between two different treatment protocols, and that makes a hell lot of a difference. So it is very important whenever somebody is doing a simple cystoscopy and biopsy. It is so important and it is so informative that it makes the difference between practically a good life and a life with maybe a lot of morbid complications.
So, regarding prostatic urethral biopsies, take a biopsy of prostatic urethra in case of bladder neck tumors if bladder carcinoma inside is present or suspected. If there is a positive cytology without evidence of tumor in the bladder, or if there is abnormality in the prostatic urethra are visible. If biopsy is not performed during the initial procedure, it should be completed at the time of second resection. Take the biopsy from abnormal area in the prostatic urethra and from the prefollicular area, that is between 5 and 7 o'clock position, using a resection loop. In primary non-muscle invasive tumor with stromal invasion is not suspected, cold cup biopsy with forceps is used. So prostatic urethral biopsies, involvement of prostatic urethra and ducts in men has been reported. Studies have shown the incidence of CIS in prostatic urethra is 11.7%. The risk of prostatic urethra or duct involvement is higher if the tumor is located in the trigone of bladder, neck, in the presence of bladder CIS or multiple tumors. Based on these observations, a biopsy of prostatic urethra is necessary. Use methods to improve visualization. We have studied that before if they are available. So photodynamic with the use of violet light with installation of ALA or HAL have confirmed that they have increased, they have more sensitivity than conventional procedure for detection of malignant tumor, particularly CIS. In a systemic photodynamic have more sensitivity than white light. Endoscopy in pooled estimate of at both patient level or biopsy level. However, prospective randomized studies are yet to be done in order to prove their. Some modern technologies that can be used are confocal laser microscopic endoscopy is a high resolution imaging probe designed to provide endoscopic histological grading in real time. It requires further validation. The STROS professional imaging system or SPICE is an imaging enhancing system used 4 different spectrum of light, but prospective data using this is still lacking.
Just a word about this STORS imaging enhancing system. I have seen a little bit of it, and obviously on a video, not particularly in front of myself, but I have spoken to persons who have been doing it. And what they do is, for instance, when you want to see something in front of you through the lens, through the cystoscope, now you can't see something which is behind it. Meaning to say, you can't see something of a shadow which falls behind anything in front of you. Now, for a shadow to be seen, you have to have a kind of a filter of light and a direction of light which should be shown um, away from the angle at which your eyes or your lens is actually seeing it. So if you have got a light which is shown from maybe a different angle, like 30 degrees from where you are, then you will have a shadow of um, that growth. Now, if you allow me, I can just draw something, but it will not be possible here. When you will come back, I will show you what this interesting enhancement system will do. Now, whenever you want to resect something, you have got something called a loop, and then you have to uh, imagine again your say imagination and your reflexes. You have to put both of them together so that your loop should be at some point behind the growth, and then you cut it towards yourself. That is known as active loop engagement. Now, when you do it, you always do it with some kind of an experience, because you are not seeing something which is behind. So whenever you want to take your loop behind a growth, then it's always um, your experience and your imagination. Again, that depends upon the time that you have spent doing it again and again. But once this system is in use, then what you do, since you are seeing the shadow, your loop is actually moving into the shadow, and then you are cutting from the shadow towards the light. You see my point? It's so
Yes.
interesting, and it is so exciting whenever a simple thing of just engaging the loop and cutting the tissue, it becomes an exciting and a thorough affair, rather than something which sometimes done in totality, giving you the complete resection. Sometimes it doesn't, and there is something which is left behind. That is known as incomplete biopsy. So it is very interesting.
So the TRBT record must define tumor location, appearance, size, and multiplicity. All steps of the procedure as well as extent and completeness should be defined. In patient with positive cytology, negative cystoscopy, upper tract should be excluded. CIS in the bladder with random biopsy. This is basically the sum of all the stuff we have been talking about previously.
Yes.
And tumor in the presence of prostatic urethra, where prostatic urethral biopsies. Now on the role of second resection or restaging. Second resection is done for detection of residual disease and tumors. Upstaging, restaging provides more tissue for pathological examination, more accurate staging, as well as the insight in the biology of the disease. Approximately 30% of the T1 tumors were found to be understaged. The significant risk of tumor residual of tumor after initial TRBT of T1 lesions have been demonstrated. So a second TRBT increase recurrence-free survival and progression-free survival with improved outcomes after BCG treatment. So regarding this, the guideline is to perform a TRBT in the following situations: after incomplete initial TRBT, in case of doubt or about completeness of the TRBT, if there is no muscle in the specimen of the initial resection, with exemption of T low-grade papillary tumor or primary CRS, and in T1 tumors. Second should be done. If indicated, perform a TURBT within 2 to 6 weeks after initial resection. The second TURBT should include resection of the primary tumor site as well. A repeat TURBT is strongly recommended in order to decrease the likelihood of understaging in patient whose tumor involves the lamina propria, even if the initial resection was complete. Retrospective studies have shown that second resection done within 14 to 42 days have longer recurrence-free and progression-free survival rate as compared to when done after between 40 to 90 days. About the pathology reporting, register the pathology report of second TURBT as it reflects the quality of initial resection. Inform the pathology of prior treatment. Pathological reports should specify tumor size, location, grade, lymphovascular invasion, unusual histology, presence of CIS. Refer the specimen from different biopsies and resection to pathology in separate label containers. So there must be coordination between the pathologist and the urologist in respect of that. A high quality of resection and submitted tissue clinical information is essential for correct pathological assessment. The presence of sufficient muscle is necessary for correct assignment of D category. Now on to the guidelines for prediction, disease recurrence and progression. So it's recommended to stratify a patient according to these groups: high risk group, intermediate risk group, low risk group. Low risk is primary solitary TA, low grade less than 3 centimeter, whereas high grade is T1, high grade carcinoma in situ with multiple large tumors. So high grade tumor is further divided into a subgroup of higher risk tumors. The subgroup includes multiple tumor, large high grade tumor with non-current, with CIS in prostatic urethra and variant histology. So this is the subgroup, and all those tumors that are not falling into any category are stratified as intermediate risk groups. This is what I've just said. So apply the EORTC risk tables and calculator for prediction of risk of tumor recurrence and progression in different intervals. We have talked about this risk table and how it can predict the recurrence and progression of tumors in different cases. In the following slides, I will show you what are the points on which we lay this foundation. So EORTC calculator includes number of tumor, size, recurrence rate, if it is recurred in first year or more than 1 year, category, more recurrence per 1 year, concurrent CIS and grade. All these have a certain score, and when we add the score, we give either the probability of recurrence in first year or 5 year, or possibility of progression in first year or 5 year. So with the help of this table, we can judge the possibility of recurrence and progression. So what this EORTC trial lacked was that the patient pool which were given BCG were very low. So in order to compensate that, the Club Urologica devised its own risk table for prediction of tumors in individuals who were treated with BCG. Risk tables, prognostic factors include gender, age, prior recurrence, number of tumor, T category, associated CIS and tumor grades. Here we can see the Spanish calculator for BCG, for patients treated with BCG. This includes as well, you can appreciate the inclusion of gender and age, which was not in the EORTC table. For further other prognostic factors include female sex, CIS in urethra, men treated with induction course of BCG, age, tumor size, concurrent CIS in BCG treated patient. Attention must be given with T1 G3 tumors in bladder diverticulum because it lacks the muscle wall. It is also a risk factor. In patient with T1 tumor, finding of residual T1 disease at second TURBT is unfavorable prognostic factor. patient with G2 tumor, T1 G2 tumor treated with TURBT recurrence at 3 months is the most important predictor of progression. Preoperative neutrophil to lymphocyte ratio is also considered as a prognostic factor. However, it needs further validation. Now, the disease management, these are the some of the recommendation for general recommendations of each. Smoking, as we have established, is one of the risk factors and should be counseled to stop smoking. However, it's still controversial whether smoking cessation in BCG will favorably influence the outcome of the BC tumors. Patient should be counseled to stop smoking because of other risk factors. Treatment should be according to the categories we have defined. In case of low risk tumor, one immediate installation of intravesical chemotherapy after TURBT. An intermediate risk factor is patient with low recurrence rate and expected EORTC recurrence of score less than 5, one immediate installation of intravesical chemotherapy after TURBT. In all patients with 1 year full dose of BCG treatment, induction plus 3 weekly installations at 3rd month, 6th month, and 12th month, or installation of chemotherapy for a maximum of 1 year. In the high risk intravesical BCG, full dose for 1 to 3 years, or radical cystectomy. And as we have defined the subgroup of highest risk tumor, radical cystectomy should be considered in those who refuse or are unfit for radical cystectomy. We can use BCG installations 1 to 3 years. So these are the treatment guidelines according to the patient. In patient with tumor presumed to be low risk and those with intermediate risk with low recurrence, this is just the explanation of all the points I've said previously. One installation of chemotherapy is recommended. For the intermediate patient, as we have said, one full dose of BCG at 3 weekly installation at 3, 6, and 12 months, or installation of chemotherapy for a maximum of 1 year. In patient of high risk full dose intravesical BCG, 3 weekly for 3, 6, 12, 18, 24, 30, and 6 months is indicated. Additional benefits of second, third year indications should be weighted in because it's BCG is costly and we face problems of BCG shortages. So it should be used accordingly. Offer TURP followed by intravesical installation of BCG when a CIS in the epithelial lining of prostatic urethra is seen. So we can offer patient if CIS is found to be present in the prostatic urethra. Patient with CIS in the epithelial lining of prostatic urethra can be treated by intravesical installation of BCG. Resection of prostate improves contact of BCG with the prostatic urethra. However, potential spread of CIS has to be considered. So suprapubic is rather not advised. Should not be done. Discuss immediate radical cystectomy with patients of high risk tumor progression. So the staging accuracy of tumor followed by TURB is low in 27 to 51% of patients. Some patients with non-muscle invasive experience progression to muscle invasive, and patients who experience disease progression to muscle have a worse prognosis. Considering all these points, we should offer or we should advise patients with these subgroup to undergo radical cystectomy. The next following will be on the failure of intravesical therapy. When the disease has recurred or progressed following the intravesical chemotherapy, they can benefit from BCG installations. However, recurrence and failure after intravesical BCG immunotherapy, several categories have been defined. Either it's BCG refractory, the tumor is present at 3 months after first course, or reinduction, a BCG relapse, recurrence of tumor after completion of BCG maintenance, a BCG non-responsiveness, or BCG refractory recurrence within 6 months of the completion of adequate BCG exposure, or development of CAS within 12 months of the completion of adequate BCG exposure, or if the patient is BCG intolerance, or it has patient has suffered from the several side effects of BCG. Considering these following these are the groups that I've just explained, different categories of BCG treatment failure. We can offer radical cystectomy with BCG non-responsive tumors. A delay might lead to disease specific survival. In patient in whom radical cystectomy is performed before progression to muscle invasive 5-year, it exceeds more than 80%. Offer treatment with BCG non-responsive tumor who are not candidates of radical cystectomy due to comorbidities, conservative strategies such as intravesical chemotherapy and microwave induction, hypothermia, electromotive administration of chemotherapy, or systemic immunotherapy can be given. So these are some of the alternative treatment plan which can increase the effectiveness of the intravesical chemotherapy. They include microwave, hypothermic, intravesical chemotherapy, and electromotive drug administration for patients who are not candidates for BCG. This is the summary of all the treatment that we have advised, which includes all the steps that I have explained in the slides prior to that. This is just a review of every management possibility. Now for the technical aspects of intravesical chemotherapy, single administration should be given within 24 hours. Intravesical therapy should be given within 24 hours to maximize the efficacy of single administration. One should advise flexible practice to allow installation not to be given as soon as possible after TURBT, preferably within the first 2 hours in the recovery room or in the operation theater. Omit single immediate installation if there is suspect of bladder perforation or bleeding requiring bladder irrigation. A clear instruction should be given to nurse to allow the free flow of bladder catheter at the end of immediate installation. The optimal schedule and duration of further intravesical chemotherapy is not defined. However, it should not exceed more than 1 year. One immediate installation of PR is recommended in all patients of low risk, and further treatment is recommended before recurrence. If intravesical chemotherapy is given, use the drug at its optimal pH and maintain the concentration of the drug by reducing fluid intake before and during installation. The length of individual installation should be 1 to 2 hours. Absolute contraindications of BCG intravesical installation are during the first 2 weeks of TUR in patient with visible hematuria after traumatic catheterization, in patient with symptomatic urinary tract infections. We can avoid these are the contraindications of BCG. However, if the BCG treatment is failed, the following are the recommendations. For BCG unresponsive, radical cystectomy is strongly recommended. Enrollment in clinical trials for new categories, bladder preserving strategies in patient unsuitable or refusing radical cystectomy. In case of late relapse, radical cystectomy or repeat BCG course according to individual situation, bladder preserving strategy is the other option. In case of low-grade recurrence after BCG for primary intermediate breast tumor, repeat BCG or intravesical chemotherapy can be given. Radical cystectomy is the other option. Now, for last part of the slide is the follow-up guidelines for the follow-up. Base follow-up of T1 tumor and carcinoma in situ on a regular cystoscopy. So cystoscopy is basically the main stay for the follow-up of the patient. Patient with low risk TA tumor should undergo cystoscopy at the end of 3 months. If negative, subsequent cystoscopy is advised 9 months later, then yearly for 5 years. Patient with high risk tumor should undergo cystoscopy and urine cytology at 3 months. If negative, subsequent cystoscopy and cytology should be repeated every 3 months for a period of 2 years to 6 and every 6 months after until 5 years and then yearly. Patient with intermediate risk TA tumor should have an in between follow-up schemes and cystoscopy. Regularly or yearly upper tract imaging for with CT IVU and IVU is recommended for high risk tumors. Endoscopy under anesthesia and bladder biopsy should be performed when office cystoscopy shows a suspicious finding in the follow-up. During follow-up in patients with positive cytology, no visible tumor in bladder, mapping biopsies or photodynamic guided biopsies and investigation of intraumbilical location are recommended. In patient initially diagnosed with TAG1, G2 tumor cancer, use ultrasound in the bladder during surveillance in case cystoscopy is not possible or is refused by the patient. Thank you.
Right. So very interesting and very elaborate. If you go back to the slide where you have shown the algorithm, yes, this one. You see, there are 2 points. One is EORTC table and its application, and the second thing is the repeat biopsy. You see, these are the 2 points that are actually not being done in proper manner at present in our institute. So there is an opportunity that we can, when we do it, it will be a very good sort of an addition into the state of affairs as is being put into practice for um, for the management of superficial bladder tumor. So there is an opportunity here for somebody who wants to go into doing some research into this topic, which is non-muscle invasive bladder tumor. So I think when you come back, then we'll discuss upon it whether we should move in that direction, because I have got some ideas behind it for further research into this thing, right? So good. So if anybody wants to say anything at this point. No. So my suggestion is we have got less time before Eid ul-Fitr, and we have got like 14 different people. So if we can do somehow 2 presentations a day, then it will be easier for us to rather wrap it up before Eid. So can it be done? For instance, tomorrow, if we can do Dr. Rahim plus Dr. Ali Mushtaba, can they do both of them in the same day? Rahim, are you listening to me? Rahim and Mushtaba. Mushtaba, are you there? No. Mushtaba, can you do tomorrow?
Dr. Mustafa?
So, Dr. Rahim, are you there?
म्यूट किया हुआ डॉक्टर रहीम जी ने चैट कर लेते हैं
Dr. Rahim, are you listening to me? Rahim? Okay, so let's talk to Dr. Arif. Arif, are you listening to me?
Yes, I can hear you.
Right.
Assalamu
So Assalamu alaikum, welcome to this forum.
Thank you, sir.
So if I remember correctly, this was your project also.
Yes, actually, it's a vast project.
Yeah.
There are so many things we can research on. As you say, deep biopsy or second look biopsy.
Yeah. I mean, this is one thing that we can add, and still it is not on in our part of the world. Everybody who sees the bladder growth for the very first time wants to get along with it, and there is an importance of doing a second look biopsy, because in many of the cases, if it doesn't change the stage, it can always change the grade. If that is so, again, that has got an implication on treatment protocol.
Yes, actually, I also feel that many of us we do under resection.
Yeah.
Because of our less expertise, or maybe because of age.
Yeah.
So many times.
Yes.
So I think biopsy or relook biopsy after 1 to 3 months, it will be helpful for the patient for completion and
Yes. Right. So, have you been seeing a lot of patients in your center?
Actually, I don't have so many patients, but I got number of patients with bladder tumor. Like yesterday, I did one TURBT of papillary growth on the left lateral wall. At the time of doing the TURBT, there was a obturator jar.
Right.
There was a little perforation.
Right.
So can I ask one question that in this situation, how can we do early installation of micromycin, which we have to give for prevention of the spillage, this things. What you are doing in this situation? Suppose there is a suspicion of bladder perforation during URBT.
Yeah. You see, whenever that thing happens and there is a strong suspicion that we have perforated the bladder, our experience was earlier when we had done it, we always put in a drain and then come out. And we always think that probably with an intravesical catheter and a drain, that smaller perforated segment or a smaller area of the bladder which has been perforated seal on itself. The experience tells us that sometimes it does happen, sometimes it doesn't. But what happens in many of the cases was the time given by us to the patient to normally respond for the healing process, the amount of urine that has been leaked into the intraperitoneal cavity, it is absorbed, and the patients more or less they go into renal failure, and it is very difficult for patients to come out of that phase. So rather than putting patient into another kind of a disease aspect, it is better to just open the case on the same day. Maybe a little 2 or 3 stitch can do the work, and it will save the patient from that effect of renal failure, which sometimes uh, is reversed and sometimes it doesn't. So many of our patients are at the age of like 50 years plus, when already the GFR is not that good. So it is rather asking for too much from the patient to heal on themselves and to cover the renal failure aspect also. So this is now the practice, that we don't wait for healing to occur on its own. We always go in as quickly as possible, maybe on the same day.
Right, you rightly said. But in case of extraperitoneal little perforation, which can be managed with the periurethral catheter, if patient don't have abdominal bulge or leak, then we can manage.
Yeah, that can be said, because you see, the peritoneal surface which is intraperitoneal is absorptive. The peritoneal surface which is extraperitoneal is not absorptive. So an extraperitoneal leak, yes, I can take your point, but you see that depends again on the kind of practice that you do. For instance, in any list in our unit, SIUT, you have seen yourself. Now there are like uh, between 10 to 20 cases of endoscopic resection. Now it is very kind of a high volume center, and we have to devise a strategy. Otherwise, it can't be just put into practice. If we take your point that if we just classify a patient according to whether it is extraperitoneal or intraperitoneal, and maybe sometimes there is the element of both, then we have made a kind of a principle here. Whenever there is perforation, it has to be opened on the same day, because we can't just wait, and we have got a lot of patients, and we have to do it again and again. So that is the, maybe since your practice is for not that much cases, it's a low volume, you can put yourself in the patient into intensive care. Patient is followed up very meticulously, then you can wait for some time.
Right, sir.
Right.
Sir, so if a patient diagnosed with ultrasound and other thing, do you do the CT scan before doing QRDT?
Normally
or
don't.
After getting muscle invasive tumor?
Yes, always, always. If we have got an evidence of muscle invasiveness, then we always go towards CT scan with contrast. But there is a little bit of difference now since the time you left us. Now, in all those cases which are muscle invasive bladder tumor, or for those who want to be a candidate for cystectomy, we always calculate EGFR pre-op as well as EGFR 6 months down the line after cystectomy, because this is some observation, and a very valid observation, that all these patients who have been through cystectomy, uh, the morbidity increases when the GFR is actually compromised, and the GFR is compromised in probably majority of patients. So we have to take care of the GFR and to decide on its actual value preoperatively, rather than just doing cystectomy and satisfying ourselves that we have done something better for the patient.
So nowadays in SIUT, how you choose the patient for the mitomycin C and BCG? For high risk group, only you are giving BCG, and low risk and intermediate you are giving mitomycin C, like that.
Yeah, but you see, the kind of situation which is, as I think you in Bangladesh is also facing, BCG is not available very frequently. So there is a problem worldwide. We don't have it. Since we don't have it, then some of the patients, they do have it on their own from, I think, from Dubai, on their own. Then we can give them. But as a policy, institutional policy, we don't have it, since it is not marketed in our country these days. So once the worldwide picture is is better for BCG, and it doesn't happen in these days of COVID. It was happening before that also, in the I think in the later part of the last year also, BCG was not available. So as far as the BCG is concerned, we just put them under bracket. Um, but mitomycin, again, it's the only thing that is available, and it's the thing that has been in use, I think, for the past many years, 20-25 years. Right. Arif, you want to say something else? Okay.
Yes, sir.
So Khudafis from all of us, for all our friends in Pakistan. I'll talk to you on WhatsApp, because there is a kind of
Okay, sir. Okay.
error in connection. So, Khudafis Arif, we'll be seeing you.
Thank you, sir. Assalamu alaikum.
Walaikum salam. Khudafis. Khudafis.